Okay. أعوذ بالله من music. Okay.
Tanggung baru nggak? Pelaksanaan penelitian. Awal ketika melakukan gerakan berjalan adalah berdiri tegak, melompat, tunduk diangkat, atau T.
Berdiri tegak dulu lah.
Nah, Bu Santi dulu. Bu Santi dulu. Bu Santi. Titik.
Halo, selamat pagi.
Selamat pagi, Bu.
Selamat pagi, Pak Suarez. Gimana kabarnya?
Baik, Bu.
Alhamdulillah, sehat ya, Pak.
Ini kan
Senang sekali.
Terima kasih.
Senang sekali bisa ketemu lagi, Pak Suarez. Kemarin Sabtu kita ketemu ya, Pak ya?
Iya, Bu. Iya, Bu.
Baik. Ini Mas Firman udah ada ya? Firman atau siapa ya? Ini Bu Eni ada nggak ya, Bu Eni? Bu Eni. PJ-nya pengukuran kesehatan sudah hadir?
Boten.
Jalan, Bu.
ID-nya
Dimatikan, Bu.
pengukuran
Dimatikan.
kesehatan siapa
Asli
ya?
wonten mriko. Tapi dimatikan, Bu.
Halo. Penanggung jawabnya pengukuran kesehatan siapa ya?
Saya, Bu.
Siapa?
Ayu.
Ayu. Yuk, Ayu. Linknya bisa Anda minta sebentar ya. Linknya untuk daftar hadir ya? Belum ada ya? Sebentar. Halo, Bu Eni.
Halo. Terima kasih, Bu. Gaji, Mas. Nggih, paling nggih Mbak Siti.
Hello, Prof. Lee. Good
Hello,
morning.
good morning, Dr. Sandy.
Yes, I'm I try to find you. I see it's here, but I saw you chat. You put the
Oh, yes, I just upload my
you show the
slides.
chat, so I know that you already come to this room. Yeah.
So are
Yeah.
you still wear the mask? You are in the office.
Yeah, because we consider that office is public area.
Okay.
Yeah, so that's why we everybody come to the public area. We have to wear mask. Yeah.
Just be cautious.
Yes. Yeah.
Well, normally I did not wear the mask in my office, but when I go outside, I wear a mask.
But in your office, there are many people. Yeah.
No, it's only myself.
But if you out from your office.
Yeah, I will wear a mask.
Oh, okay. Yeah.
It's just a short break.
Yeah, 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 yeah.
Wear mask is not comfortable. I mean, all day.
Yeah, yeah, yes. Yeah. Maybe we are waiting for a moment,
Sure,
Prof. Lee. Yeah,
sure. Yeah, we can wait for.
yeah,
So how many students will be in these courses?
yeah. Actually, this class is only for the third year of
Yeah,
undergraduate
yeah.
program
You
for
told
public
me. You told
health.
me.
Yeah. But finally, we decided to offer also this class for others program.
Okay. Yeah.
Yeah,
No
so
problem.
the student come here not only from our program, but they come also from other program and also
Sure.
for not only for University of Erlangga. Yeah, because we also offer for the student from university in
Mhm.
East Java.
Oh,
Yeah,
okay.
yeah.
So
Because
greater area.
yeah, because this topic is very important to everybody if they have to do a research, if they have a program, they have to know the validity and reliability of
Yeah.
every measurement. Yeah,
Yeah, that's right.
yeah.
I don't remember there is a scientist, very famous scientist, who ever said that all sciences are measurement.
Yeah, yeah, yeah,
It's
yeah.
about all sciences are about the measurements.
Yeah, it's all sciences. Sciences is about measurement. Yes, yes.
Yeah.
Yeah, it's in daily life. Yeah. If
Yeah,
we,
no matter you're in the laboratory or in a
yeah,
community, you use a different variety of different tools.
yeah, yeah. Also in our daily life, if we have to know our body weight, it's a
Ah,
measurement.
yeah, it's a
Yeah.
measurement.
I would like to show the poster that I to announce this lecture.
Sure. So have you received the slides that I just uploaded? Can
Not
you
yet.
can
Not yet.
everyone, because I already upload
No.
in the chat
I
room, in the chat room.
in the chat room.
Yeah,
Okay, I will check
I
it.
upload
Yeah.
a
Okay. Yeah,
file.
yeah.
Okay.
We can yeah.
Yeah, you can. Everyone just can download it, so that will
Yeah.
be easier for them to follow my lecture.
Yeah. I will announce to the student ya. Mahasiswa ya, Prof Lee mohon maaf bisa di mute dulu yang tidak aktif. Prof Lee sudah posting materinya hari ini di chat room. Anda silakan bisa gunakan itu ya. Sudah tahu ya? Halo, mahasiswa.
Sudah, Bu.
Oke. Ya.
Yang baru masuk kayaknya belum dapat.
Oh, yang belum masuk belum dapat ya. Nanti mungkin kita bantu lagi posting ya. Sebentar, saya tak tunjukkan dulu slide-nya ya buat Prof. Lee. Tapi yang sudah dapat bisa bisa download slide-nya ya. Halo, mahasiswa.
Sudah, Bu.
Oh sudah.
Sudah, Bu.
Anda mungkin bisa respon di chat-nya situ. Anda tulis thank you atau apa ya, sehingga Prof. Lee bisa tahu kalau chat slide-nya sudah bisa di-download oleh Anda. Please respond for itu, for Prof. Lee's lecture ya. Tolong di chatnya itu Anda apa namanya? Anda tulis terima kasih, thank you, or something else ya. Sehingga Prof. Lee bisa tahu kalau itu Anda sudah dapat. Gitu? Oke, sebentar ya.
Excuse me, Dr. Santi.
Yeah. Okay.
I just joined your meeting, but I don't have the material yet. Can you put
Okay.
it
Okay,
again?
we can posting again, yeah?
All right, thank you, Dr. Santi.
Yeah. Where are you from?
I'm Emir.
8 year.
I am Emir.
Oh, Emir, how are you, Emir?
Hi, Emir. How are you?
Yeah,
Hello,
Emir.
Professor.
I think almost 1 year, yeah. We didn't met yet, yeah, Emir.
Yeah. Yes. It's been a long
Yeah.
time.
Yeah, nice to meet you, Emir.
Yeah,
Nice to meet you
Emir.
too, Professor.
Yeah. Emir accompany you, Prof. Lee, yeah?
Yeah. Last time when I was in Surabaya.
Yeah, yeah.
She is very kind, young
Yeah,
faculty.
yeah. Prof. Lee,
Yeah.
did you see the poster?
Yes, I saw it. Yeah.
Yeah.
Very nice
So,
looking.
yeah.
Yeah, thank you.
Yeah. So finally we decided that this topic is very interesting and very important to every student to know it. So that's why we create the poster and then we share the announcement with this poster to our student in Faculty of Public Health and also to students from other faculties and also from other universities. Yeah.
Thank you.
Yeah, thank you, Prof.
Yeah,
Lee.
hopefully I can make myself clear
Yeah.
in this presentation.
Yeah, okay. Thank you, Prof. Lee.
Yeah. So can I start it now?
Yeah, yeah.
Okay.
Okay. I would like to open first, yeah. To open this class. Good morning, everybody. Today we are in the second meeting of our subject about health measurement, and now the topic is about validity and reliability of health measurement. And we have our adjunct professor now, Professor Chung Lee from National Cheng Kung University, Taiwan. So, Prof. Lee, please, it's your time to give the lecture. Yeah. Thank you, Prof. Lee. It's very kind to meet you again, although virtually, yeah. And
Thank
we
you.
can start also the program earlier than before, yeah?
Yeah.
From March, yeah. Thank you very much, Prof. Lee.
Thank you, Dean Sandy. And actually, now I can share my screen. Is that working?
Not yet.
Not yet.
Yeah.
Let me try it again. How about this one?
Yeah.
Yeah, okay.
Yeah, we can see it. Yeah.
Okay. So let me, first of all, I would like to thank you, Dr. Sandy, for her introduction. And actually, we have been suffering from this COVID-19 pandemic last year. And hopefully, we can back to normal, no matter whether it's in the end of this year or early next year. Hopefully, it's end of this year because I know that there is a big event in Surabaya. In the end, we were going to have our APEC meeting in Erlangga. So hopefully this meeting will come true.
Yeah, hopefully.
Today I'm going to talk about the measurement, but not only the concept of the measurement, but also the statistic assessment. But I'm not going to detail about statistics because actually most of the students here are undergraduate students, and of course, for undergraduate students, they are doing some simple research and also use some tools. They must also know the concept of validity and the readability, but the statistic issues are a little bit further complicated, and hope that will be most appropriate for the graduate students. But because we cannot only say the concept of measurement, so I will say something about the statistics, but just some basic concept here. If you are interested in further insight, because we only have 2 hours to talk about these issues, if you are really interested in the concept and the statistic approach, you can try to find the information that you need from this book. And I feel that this book is very useful. Actually, now is the 5th edition of this book. And when I was a PhD student, I read the first editions. That's back to more than 20 years ago. And actually, I keep following this book. I think it's very creative and very useful if anyone who are going to know more about the measurement, and then he or she can refer to this textbook. And some of my contents were from this book. So now we need to start the definition. Every time we're talking about the measurement, we're talking about 2 things. The first one is validity. The second one is reliability. And there's other terminology which are equivalent to reliability. It can be sometimes called reproducibility and sometimes called precision. So if someone want to sell you a scale, for example, sell you a scale to measure your body weight, of course, of course the price is important, but before asking the price, you had to ask the salesman about 2 things. The first one, is this scale valid? I mean, if this scale valid, it means that this scale, the body weight scale, will give you the accurate information about your body weight. And the second issues that you have to ask the salesman about this scale is how reliable of this body weight scale. The reliable means this scale can reproduce the body weight consistently when you repeat the measurement. For example, when I have a body weight scale and then I stand up on the scale for 10 times every 10 seconds, I stand up and walk down, stand up and walk down. When I stand up on the scale for 10 consecutive times, and this scale tells me that I have 80 kilograms. The first time saying I'm 80 kilograms, the second time 80 kilograms, and this scale consistently told me that my body weight is 80 kilograms. So this scale is pretty consistent. In other words, this scale is pretty reliable, very precise. But the truth is that my body weight is not 80. My body weight is 83 kilograms. So even though this scale is very reliable, but this scale does not tell me the truth. The truth is that my body weight is 83. So even though this scale is very reliable, but this scale is not valid. So these are the 2 concepts. We cannot say that this scale is reliable and it must be valid. So we have to talk about these 2 concepts separately when we are making assessment of the scale. And I'd like to address the important issue is that both validity and reliability are a matter of degree, not all of nothing. In other words, we cannot say only this scale is valid or not valid, because the validity and the reliability can be assessed by a coefficient. which range from 0 to 1. So it's a kind of degree. You can say that this scale is valid with a coefficient like 0.8. It is good. But sometimes the validity coefficient is 0.2 or 3. It's low. It's not so good. So it's not always yes or no question. It's a degree, a matter of degree. I think many of you have seen these pictures in the textbook. So, like just in the shooting on the target. So if we have the upper left here, we have 10. How many shots here? 9. We have 8. Sorry, we have 8 shots here. If you look at the pictures in the upper left, we can see that all the 8 shots are on the same target, very close to the center of the target. So we can say that this in the upper left pictures, the measurements are pretty valid because all the shootings are right on the target. And also people see the upper right. The upper right, we can see there are also 8 shooting, and all of them are shooting very almost on the same places. But the problem is, if you see the upper right pictures, all the shootings are away from the center of the target. So in epidemiology, we call it's kind of systematic bias, because even though those shootings are on the same places, but they are not on the right target. So for the pictures on the upper right, we will say the measurements are precise. Our reliability are very, very good, but lack of validity. The validity is low. Look at the pictures in the bottom on the right side. So you can see that all the 8 shootings are very sparse. They are not on the same places. So the bottom right picture shows that the reliability is pretty low. And also the reliability, the validity is also low because all the shootings are away from the target. So now we have 3 situations here. The upper left is high validity, high reliability. The upper right is high reliability, but low validity. And the bottom right is low reliability and also low validity. How about the number 4 situations? Can you imagine the number 4 situation? What is supposed to look like? There is another situation is high validity, but low reliability. Yeah, I will remove the mask here. It's what looks like all the 8 shootings are sparse. They are not consistent on the same place. But when you take the average, of the 8 shootings, and the answer will be on the right target. So people say that in the bottom left, there is a tool, there is a measurement with low reliability but high validity. But when you think twice, when you think the situation, if there is a salesman wanted to sell you a tool to measure the blood pressure, and this salesman will say, our company, our product is very valid, but it's not reliable. As I say that you have to ask the salesman the 2 things. How reliable are your blood pressure machine? How valid is your product to measure the blood pressure? So if the salesman saying that our product is not reliable, it means their blood pressure machines would not produce the same result even though they took the same sample, blood sample. But they will say that if you take the repeated measurement, and it will end up with a right answer if you take the average. Well, it sounds ridiculous because when every time we're talking about the validity, we are not supposed to say that we have to repeat it measurement, take the many times and take the average. We like a machine or the tool, just like the upper left. So actually, later on, we will show you from the statistical point of view, the bottom left, this type of combination does not truly exist in the real world. In other words, it's unlikely to have this kind of scale. So only we have 3 combinations. We don't have the bottom left situations in the real world. So we all know that high reliability does not guarantee the high validity, just like the scale I just previously mentioned. There is a body weight scale told me that I am 80 kilograms for 10 times consistently, but actually my body weight is 83. So the scale systematically underestimates my body weight. So even though the scale is very high reliability, but the scale does not have high validity. But the same question is, does high validity sufficiently lead to high reliability? And the answer is yes, because when a scale or when a tool or machine, a measurement is valid, it also means that this scale is reliable. We all know that reliability is a necessary but not sufficient condition of validity. So in order to say that a machine or a scale is valid, this scale must be reliable in the very beginning. If a scale is not reliable, then we will say not this scale is valid. So validity is much more important than reliability. When a scale is valid, it means that the scale is reliable. But when a scale is reliable, it doesn't necessarily mean that the scale is valid. So if you do not have much time or resources to make the assessment of your scale, then you have to choose the assessment of validity first, and then later the reliability. Because if you can prove your tools or your scales are valid, it means your scales are reliable. So only the validity can guarantee the reliability, but the reliability, high reliability does not guarantee the high validity. So now we're going to some statistical concept. I think everyone in this online courses must know about the ANOVA, the analysis of variance. You know you learn the statistics. You know that how to analyze, compare the differences in multiple group means by using the analysis of variance, which is called ANOVA. Now my question is, suppose now we have 30 students, well actually now we have 185, but suppose we have 30 students in these courses now. And I'm sure that if we have 30 students here, everyone, their body weight may not be necessarily the same. There is a variation. And my question is why the body weight for every one of us are not entirely identical? Why the body weight for every one of us are not entirely identical? Why I'm 83 kilograms and you only have 50? Why somebody, Chung, has 90 kilograms, why Mary is only 60 kilograms in her body weight? So everyone may have a different body weight. And why? Well, the answer is quite simple. Maybe you will say that, of course, many determinants that can be associated with a person's body weight, because we are different ages, we're different genders, and sometimes the body weight are determined by the genetics factors. And of course, nutrition is also a key factors, and lifestyle. Everyone, sometimes some people will go to the fitness room to exercise every day on a regular basis. And some people will, sitting in the office or sitting in front of the TV for the entire night. So many people, many determinants will account for the variation of body weight among us. But when you are talking about these potential determinants, you agree that the variation in body weight among us is true. Maybe you will think about the other things. Maybe our body weight are identical. We are all have the same body weight, but just because there is a scale which involves some measurement errors. So, this measurement error will cause the inconsistency of body weight among us. Maybe we are all the same body weight, but just because we use a measurement scales, which is low reliability. Low reliability means this scale will give a random answers to our body weight, even though our body weight are the same. So why we have a variation among the body among us in our body weight? It could be due to the true reason. The true reason will be like we just mentioned, because we have different ages, gender, genetics, and it also could be due to a reason this is not true. It's due to the measurement errors. And we know that the errors can be categorized into two parts. The first one is systematic errors, and the second one will be the random errors. So every measurement are involved in two types of errors: random error, systematic error. The body weight scale that I just mentioned to you, the scale take the measurement of my body weight for 10 times and keep consistently told me that I'm 80 kilograms. But the truth is that I weigh 83 kilograms. So this scale is has a systematic errors, which every time will underestimate my body weight by 3 kilograms. So that is a systematic errors. So now if we use the variance component to define the validity and the reliability, we can see here there's formula. It's very simple formula. The left will be the total variance. And the total variance can be divided into 3 parts. The last part will be the variance due to error. And we have the 2 parts, components of the true variance. The first one, S square V, is a systematic error. And the SV square is the true variance, which is the age, genetics, nutrition, lifestyles. And the SI square is the error, but which is systematic. And the third component of the variance is S square error, which is the variance due to errors. So if we use the variance component to define the validity and the reliability, and we can see that for the reliability, the denominator will be the total variance, and the numerator will be the SV square plus SI square. In other words, if a scale has a very low random errors, its reliability will be very high. For example, if SE square is equal to 0, the reliability will be 100%. But when we are talking about the validity, not only the square error, not only the random error, but also the SI square, which is systematic errors. So the validity does not allow any types of errors. So if a scale did not have any type of scales, do not have any type of measurement errors. It's free from systematic error and also free from random errors. And we can say this scale has high 100% validity. So the validity is free from systematic error and random error. The readability only free from random errors. But the readability allows for systematic error, just like the scale that told my body weight is reliable, but it's not valid. So systematic error is allowed in the reliability. So if you look at the formula here, we can see that the readability is always greater than validity for the same measurement. I will say again, for the same measurement, reliability is always greater or equal than validity. So that's the reason why I just told you that validity is much more important than reliability. If I can prove or if I can assure that the measurement is valid, then this measurement will be reliable. Because all the validity and the reliability coefficients are ranging from 0 to 1. It's a coefficient. So suppose we have a measurement with a validity of 0.7, and we can assure that the reliability for that measurement will be equal or greater than 0.7. So it's not possible, it's not likely that the reliability will be smaller than the reliability. No way. Because when you see the formula, you will see that reliability coefficient is always greater than validity. So for the researchers, we must make sure that our measurements are valid. If our measurements are valid, it means our measurements are automatically reliable. But when we have a reliable measurement, it doesn't guarantee that our measurements are valid. So these are the concept of validity and reliability. Now, everybody see the papers, and you probably will see the different name of validity. Most of the textbook, they categorize validity into 3 different types of validity. And when you are using the assessment of validity, you must choose at least one of them to perform the validity assessment. If you are going to use a questionnaire in a community to do your research, you must make sure that your questionnaire are valid enough. So you can choose either to make assessment of content validity or criterion validity or construct validity. I will go on for one by one to let you know the meaning of the 3 different types of validity. And I also I will give you some examples. Some of the examples are my own studies. Some of the examples are the study by somebody else. Just give you some concept about those different type of validity. So we'll begin with the content validity. The content validity means the extent to which the test items relate to a domain of the items. And sometimes you will see the different name of the content validity. One is expert validity. The other is phase validity. So we'll begin with the content validity. Sometimes the content validity was called expert validity, logical validity, or sampling validity. The concept of the content validity is that the main measurement covers a representative sample of the domain to be measured. Are the elements of the test represent only the domain related to the concept? Assessment requires the rational analysis of test contents. For example, if you're going to measure the quality of life, and you must know that what kind of domain must be included in the quality of life. Or if you're going to have a measurement of the mathematical capability, we learn the mathematics in our high school, in our elementary school. If a school teacher wants to give you an examination for the mathematics, this teacher is going to make assessment of your proficiency or your capability or your understanding of the mathematics. So these school teachers must include some representative samples in their test. For example, I don't know what contents were taught in Indonesia high school, but in Taiwan, for high school mathematics, we have to learn probability, a combination. We also have to learn algebra, or we have to learn the probability. So these are the important items or domains that should be included in the test, because for the high school mathematics, the high school teachers teach a different domain of the mathematics. So if the school teacher is going to test a student's capability, he or she must create a test that choose some items from those domains. And whether or not this test does cover all the domains to be measured, we must be evaluated by some experts. Or you can examine the content of the test to see whether or not there is adequately samples being sampled from those domains. So this is kind of a expert validity or logic or sampling validity. But sometimes, you know, the researchers just does not go through a very systematic evaluate of the expert validity. They just go in a very superficial appearance of the test, which we call the face validity. The difference between the expert validity and the face validity is the expert validity takes a more systematic steps and will give you some indicators. I will show you later, saying that the degree of the validity. But for the face validity, it will give you only a very superficial assessment of the test. But both validity assessment belong to the content validity. For the criteria-related validity, this is the second type of validity, and it also can be categorized into two parts. Sometimes you will hear about the concurrent validity. The second one is predictive validity, and both validity belong to criterion-related validity. The concurrent validity, which is the validity indicator that we commonly use, is the extent to which the score from a test related to the results obtained from administering another presumably valid measure to the same subject within a short time frame. For the criteria-related validity, there must be one condition. The condition is that we have a gold standard. If we have a gold standard, then we can perform the criteria-related validity. I will give you a short example, a quick example about the concurrent validity. I think when you are a graduate from Atlanta, you have to find your job. Let's suppose when you go to a computer company, they are going to hire a programmer, and the company manager will take a face-to-face interview because you are going to find a job in that computer company. So the company manager probably will ask you, can you write some programs? Can you use the computer? Like, can you use a word? How many words you can type within 1 minute? And can you use the SPSS to do some statistics analysis? Of course, because you want to that job, then you probably will tell the project manager saying that, yes, I'm able to, to use the word I'm also capable of using SPSS to do the statistics analysis because I learned from Erlenga. And you will say that I'm very skillful. I can type like for 100 words within 60 minutes, 16 seconds. Well, of course, you can say anything to show yourself, to you know, say that to say the company manager saying that you are so so capable. But when the interview ends, the company manager will tell you, okay, this young lady or young gentleman, you can go to the next room. We have a very short, very simple test for you. It's a statistic problems. I won't let you, use this SPSS trying to, just to solve the problems. Well, you say many words. You say a lot of things about yourself. You say that you're capable or blah, blah, blah. You say a lot of things about you. But the company manager will give a real world example and ask you to sit in front of the computer and try to solve that question using the SPSS. So there is a gold standard. No matter how much you say to the managers, you have to prove yourself because they are using real world examinations and ask you to finish that exam. So if you are, say many things about yourself, but you got a very low score in that real world exams. In other words, the face interview would have a very low validity because it does not give a real capability that you have. And for the predictive valid, which is very similar to the content validity, the only difference between concurrent validity and predictive validity is the gold standard does not appear within a short time. It must be appear for like several months or several years later. For example, in our public health, in the community, we do a lot of cancer screening. For example, in Taiwan, we in the community there are 4 cancers. We are very focused on community for the cancer screening. The first one is oral cancer, and breast cancer, cervical cancer, and colon cancer. Because the 4 cancers in Taiwan are increasing. So we do have a community cancer screening programs for the 4 cancers. But you know that the cancer screening is using a very simple, easy, low-cost tools in the community. When a person receives a colon cancer screening and find a positive result, these persons will be referred to the hospital to go further examinations. So the predictive validity is that when we are using a very easy, simple tools to make the measurement, but we are not sure whether or not this measurement is valid or not valid, but we cannot give the right answers in the community because the persons will be referred to the hospital to go for the further examinations. And the answers will be no, like several weeks later, because sometimes when the people got a positive result at the community cancer screening, maybe it's just a false positive findings. So the gold standard will be the examination in the hospital, because in the hospitals, the doctor will do a series of examination to confirm this positive result is true or false. So sometimes because we consider the cost, the invasiveness, or whether or not this tool is high risk, or whether or not this measurement costs a lot of time, we normally use a very simple tools, but the gold standards are there. So we have to compare our measurement with the gold standard and to see whether or not our measurement is valid enough or not. and depends on when the gold standard can come out. If the gold standard come out within a short time frame, we can say it's a concurrent validity. If the gold standard will come out, for a long time later, like several weeks or several months, then we can say that this is type of predictive validity. The third type of validity is called construct validity. The construct validity is a little bit complicated, especially from the statistic point of view. When the gold standard is not available, then we have to perform the construct validity. For example, quality of life assessment. We know that there are different scales that can be used to measure the quality of life in a community. And also, we know, in the hospitals, we always, to give a questionnaire about the patient satisfaction. How satisfied the patients come to see a doctor? How satisfied the patients feel when they receive the services from the hospitals. So patient satisfaction is also a kind of scale that should be assessed by using construct validity, because no matter satisfaction, quality of life, or depression, anxiety, sometimes those are subjective, like pain, how painful or what level of pain, how much pain you feel when you finish your surgery. So a lot of things cannot be measured directly, and also there's no gold standards. Everybody knows that this is a gold standard, like a quality of life. I'm sure that you must see different scales that can be used to measure the quality of life. And no one said that which scale is a gold standard, because the different scales would have different purpose, and they can be applied to different populations. So when we are doing the assessment for some scales that without any gold standards, we have to perform the construct validity. Also, there are two types of construct validity. The first one is convergent validity. The second one, discriminant validity. The concept of convergent validity is quite simple. Let's suppose we have a test A, which is supposed to measure the health. You know that the health is not easy to measure. It's not only just, do you have any diseases, or you have any symptoms? It's not so simple. Sometimes health covers a wide range of domains. It can be a psychological, physiological, social, or environment. So the health is a broad concept. It's not easy to measure. Now, suppose I have a test A, which is supposed to measure the health. Then I can compare the result of test A to the other variables, which are on the same direction of health. For example, age. We know that age is highly related to health. We know the number of doctor visits in a year is very related to health. So if the test A is highly correlated with age and the number of doctor visits, we can say the test A shows some kind of convergent validity. But I want to address here, assessment of construct validity is an ongoing process. You'll see the blue color text. It's an ongoing process. No single study or evidence are sufficient for proof of construct validity. So it's not only based on one single study, you have to continue to make assessment just to increase the level of convergent validity. And for the discriminant validity, it's on the opposite. For example, there's another test we call the test B, which is supposed to assess the verbal skill of somebody. We know that people are healthy, they probably do not have very good capability in their verbal skill. You know that some people may be able to speak Bahasa or Chinese, English. Well, some people have very good verbal skill. They can speak a lot of languages. But this is not related to health. I mean, the level of health probably do not have the same level of verbal skills. So based on that concept, if I give the two questionnaires, test A and test B, to a group of persons, I would suppose the correlation between test A and test B are pretty low, because they are not supposed to measure the same concept or the same construct. The test A is supposed to measure the health. The test B, on the other hand, is supposed to measure the concept of verbal skill, the language skills. So they are different concepts. So the correlation between the two are expected to be low. If when I do this kind of analysis and I find that the correlation between test A and test B are pretty low, then I would say test A shows some level of discriminate validity, because test A can discriminate health from verbal skills. Okay, then I will give you some examples about the three types of validity: content validity, criterion related validity, construct validity. The first one is the paper published in the Journal of Clinical Nursing. This is one paper that I involved in, which is done by a graduate student from the Department of Nursing. Ms. Chen, she did research about the predictor of fatigue in patients with heart failures. So in these studies, the conceptual model for her study is people who are suffering from heart failures, the patients will feel fatigue. But what are the potential determinants of fatigue? The researchers propose there are different determinants. The first one will be the physiological factors, which are easy to measure because it's a symptomatic distress, and also NYHA functional class, which is a scale that can be used to measure the problem of heart. And also the second category will be psychological factors, for example, anxiety, depressions. And the third one will be the social support, situational factors. So the research say that these three categories of factors can be associated with fatigue. So actually in this research, the researchers use quite a lot of scales to do the measurement of physiological factor, psychological factor, and situational factors. And I only take one example just for illustration purpose: symptomatic distress. The researchers use like 17, I think, yeah, 17. They asked the patients with heart failures, do you feel tired? Or did you feel short of breath during exercise? Do you feel lack of energy? Do you feel it's difficult for you to sleep? All the items were asked. I mean, all the patients were asked by each items. So I think it's a 5 Likert scales from 1 to 5. If you score 5, means it's always feel tired. If the patient score 1, it means not at all. I did not feel much about tired. So every patient just give a number here. So the authors use 17 items, this scale, to measure the symptomatic distress for the patients with heart failures. The author must provide some information about validity. Because these scales do not have sufficient validity, and the scores obtained from scale will be questionable. So you can see that in the papers, the authors say the content validity of the Symptomatic Distress Index were reviewed by 2 cardiologists and 3 nurses, cardiovascular nurses experts, who indicate a content validity index of 0.8. So this is a coefficient of content validity. How to calculate the CVI? I'm not going to go through detail about the calculation because it's not a statistics courses, but you can check the reference. Every time when we are talking about the content validity, we have to go through a systematic method. For example, I just finished one content validity. This is in Chinese, but my personally, I do not have the English questionnaire because here in Taiwan, we always use the Chinese questionnaire. But it's okay. I just want to let you know that how, in order to calculate the CVI, what kind of information we need. This is a questionnaire that I just working with my colleagues to see the working environment of the workers who are working in the long-term care facilities. In Taiwan, we have a lot of long-term care facility because people in Taiwan getting older and older. So a lot of elderly people who need long-term care. And you know that the people who are working in the long-term care, they must be very tired. They have to spend a lot of time taking care about the residents of the long-term care facility because many long-term care facility residents, they're disabled. So the working environment is very important for the health of the workers. So every time when you are going to access the CVI, you have to ask the 3 things for each item. Is this item important? Is this item relevant? Is this item clear enough to be understood? So the 3 parts will be, so in this questionnaire, we ask the expert because we are now doing the expert validity. For example, the first question here is, do you feel that the workplace that you are working is very good or very poor? The second question is, do you feel friendly, environmental friendly when you are working in this place? And the number 4 will be, do you worry about if there is some kind of disaster like fire occur during your work? Because in Taiwan, sometimes we have some accident in the long-term care facility. It's a tragedy because when a long-term care facility got fire, you know that many disabled elderly, they will not be able to escape from the facility. So the fire events are important. So we ask the workers in a long-term care facility, do you worry about if there are any accident happen during your work? So we ask a lot of questions, trying to see, whether or not the working environment is good or not. So the quality of working environment is a concept that we're going to measure. The quality of environmental working environment in the long-term care facility. So for each item, we ask the expert how important this item is, how relevant this item is, how clear, how unambiguous, how clear, because sometimes, the statement of the item is not clear enough. The people who be interviewed will, misunderstand. He or she will misunderstand the meaning of the items. So when the score, under the score of 2, the research have to revise the scales. And we would like to see the comments from the experts. So this is kind of expert validity evaluation process. So if we have those information, and then of course we can calculate the content validity index and to show whether or not our scales can be used to measure the environmental working quality for the workers working in the long-term care facility in Taiwan. Yeah, this is all the questionnaires. Now we move to the second type of validity, which is called criterion-related validity. Remember, I told you that for the criterion-related validity, we must have a gold standard. So we have to compare the gold standard and the measurement that we obtain by using our scales or our tools. This is the one example about the concurrent relative validity. This is done by my colleagues and myself. You know that in Taiwan, we have a national health insurance programs. Everyone in Taiwan covered by the national health insurance. So we only need to pay a very small amount of money to see a doctor, because all the medical outpatient or inpatient services were covered by the government. So we only need to pay a small amount of money for see a doctors. So this is called the national health insurance. So in Taiwan, including myself, we did a lot of study based on the national health insurance medical claim database. But the problem is how accurate of this database. You know that some doctors, they may not have much time to write down or to to give a right diagnosis code. And sometimes some doctors, they are afraid that their code will be rejected by the government. So for example, if a doctor is speculate a patient with a diabetes, so the doctor will order a blood test for these patients. But later on, the doctor finds that the blood test, the result is normal. So this patient is okay. This patient does not have diabetes. But these doctors probably will give a ICD-9 code for these patients just because doctor wants to order a blood test. So many people say that the national health insurance claim data may not be 100% accurate. So we just conduct this study to make the validation of the diagnosis of acute ischemic stroke. Because this stroke, the prevalence is pretty high in Taiwan. So the gold standard will be, we use the data from our hospital, NCKU hospital, because we have to submit our medical claim to the government in order to get the reimbursement. So totally 1,736 patients with the stroke, ischemic stroke, were reported to the government. And we also use the Taiwan Stroke Registry. This is a registry database, and the TSR is based on a very detailed information about stroke. So all the hospitals in Taiwan, the neurologists must be reported to the TSR, to this database. So we will consider the Taiwan Stroke Registry database is the gold standard, because it's not for the claim purpose, it's for the research purpose. So we will feel that the TSR can give a more accurate information than the national health insurance. So we just compare the two data sets based on the 1,700 patients reported from NCKU hospital. I'm not going to detail about the linkage, but the result is to look like this one. This is the result of TSR, and this is the result of the national health insurance. So we can see that most of the records, we can see they are consistent between TSR and NHI. But we can see still there are some inconsistencies here. Here we have 202 patients who are considered stroke patients in the TSR, but they do not consider as ischemic stroke in the National Health NHI records. So if we took the TSR as a gold standard, we will say that the 202 are false positive. And also we have 42 false negative, because those 40 patients who are the AIS patients at the TSR, but they are not the ASI patients in the NHI. So the 42 patients were considered as false negative. So based on the numbers here, we can give information about how valid of using NHI database to do a research about ischemic stroke. So the authors just instruct the authors, if you choose, because for each claim, we have at most, we can have a diagnosis up to 5 diagnoses. So if we use only principal diagnosis, the predicted value of positive will be only like 76.1%, but sensitivity is 96.9%. But if the investigator use all 5 diagnoses, and the PPV will increase 88%, and the sensitivity will increase slightly from 96.9% to 70.3%. So the conclusion is that when you are using the NHI database, we will suggest that you probably will examine all the diagnoses, not only the primary diagnosis, because probably the ischemic stroke can be places in any places of the 5 diagnosis codes. Yeah, this is another study we published in PLOS ONE. Actually, is a type 1 diabetes, the incidence and mortality. And the reviewers also asked us to do a validity analysis to see whether or not the NHI data on type 1 diabetes is accurate or not. So actually, in doing this validations, we use the chart from National Chung University Hospital, and we select 60 patients with T1DM, and we find that 59 of them were recorded in the NHI database. So it's pretty high. I mean, when we have 60 patients, the NHI they are truly. In other words, if we identify 60 patients from NHI and 59 of them are truly type 1 diabetes, so the predict value is very good. But here I want to mention to you that actually many people, just like my colleagues, we use the PPV as the indicator for the criteria related validity. I would say that it's not a good one. The best way is to use the sensitivity and the specificity, not using the PVP or PVN, because PVP and PVN can be substantially influenced by the prevalence of disease. So if I can suggest, I would suggest to use the sensitivity and specificity, not using the PPV. The PPV is not a good indicator for criterion related validity. The reason is that I can show you this artificial examples. If a physicians want to use a fever to screen malaria, well, whether or not the patient has a malaria, you must be taking the blood samples from these patients. Because if the patient is infected by malaria, we can see the sign in the blood samples. But we all know that for many people who infect by malaria, there is a symptom, which is fever. Let me ask you questions. This is a conditional probability here. If a patient comes to doctor's office showing the symptoms of fever in Europe, what's the probability that this patient truly have malaria? What's the probability? It's likely to be 0, right? Because not only malaria, but there are some other diseases will cause fever. So if this doctor is in Europe, the probability of fever, conditioned by fever, and this patient truly have malaria, the probability will be very 0, will be very low. But if this doctor is practicing in Southeast Asia, and if one patient show a sign of fever, and what's the probability of this patient truly have malaria? I think the probability is not always 0. It could be small to moderate. So the two doctors are using the same method, fever. They use a fever as a measurement of malaria. If this doctor practice in Europe, this measurement will be very low validity. But if this doctor is practicing in Southeast Asian countries, the probability would be higher, because in people in Southeastern Asia countries, the prevalence of malaria is a little bit higher than the countries and peoples in Europe. So the same measurement, I mean, using the fever to measure the malaria, and we will see that the PPV is quite different. So that's the reason why I say that the PPV is not a good indicator for the criterion-related validity. So everyone calculate the sensitivity and the specificity, which are the good indicators for criterion-related validity. Yeah, this is just a formula for your reference. Yeah, this is how to calculate the sensitivity, specificity. I think that you learn this concept from epidemiology or the cancer screening courses. Yeah, it's a trade-off between sensitivity and specificity. I will go through about this one and RC curve. Yeah, then I think I will skip several slides to move forward about the other things about yeah, I will skip this one. Yeah, this is a predict criterion validity. The only difference is that the criterion will occur later, not at the same time. But for the example that I just give you, the concurrent validity, we can see that the two database can coexist simultaneously. So this is one example. Also, I'm working with my colleagues. We are trying to create a very simple scoring algorithm to predict the vascular infections in patients with non-typhoid Salmonella bacteria. And we know that the people who are infected, the bacteria, they have a chance of getting the vascular infection. If the vascular infection occurs, the people will like to get sepsis, which is very fatal, endanger the life of the patients. So the doctors in our internal medicines, Dr. Chen, he likes to to create a very simple scoring algorithm, trying to use this algorithm, a score, to predict whether or not the patients who are infected by the non-typhoid Salmonella bacteria would have a chance to develop vascular infections. So actually, they use the NCKU hospital to the data from NCKU hospital to compare the patients who develop vascular infection and the patients who do not vascular infection. And those almost 400 patients are infected by non-typhoid Salmonella bacteria. So here we can see that they do have some significant difference in gender, hypertension, CAD, whether or not the patients are receiving immunosuppressive therapy, and also malignancy. So the Dr. Chen just used the 6 variables here to calculate a score, trying to create score systems. Here, because those variables, 4 of them are risk factors for vascular infections, and the other 2 are protective factors. Some factors are risk factor, some factors are protective factors. So they just use the 6 variables to get some scoring algorithm. They use a different scoring algorithm, model 1 and model 2. And then end up with a very similar result. We can see that the sensitivity and specificity is very good for the model 1 and model 2. And the ROC curve shows that the area under the curve is like 0.82 or 0.83. So this is a validity coefficient because we have a gold standard. Whether or not the patients truly have the vascular infection, we do have this from the chart. And based on the 6 variables, we create a predicting score algorithms. And this research shows that this algorithm is pretty valid. Then we move to the construct validity. This is also an example. Professor Chen, also my colleagues, she used from the nursing department, she used 1 single item to screen the elderly persons for the oral health. So here she used a different scales like SSF. SSF means a social support questionnaire, mini nutritional scales, and the UCLA lonely scales. So here we can see that for the people who do not have a teeth, we just ignore this group because people who do not have teeth, the elderly people would not go to see a dentist. And we can see the right side here. For the people who have a teeth, we can see that 75 of them, they went to see a dentist on a regular basis, and 72 of them, they do not see a doctor, a dentist on a regular basis. So can we just ask 1 single question about whether do you see a dentist on a regular basis? Can we use this single item to measure the oral health of elderly people? But here we can see the GOHAI and the BOHSE are the scales for the oral health of the elderly people. So we can see that for the people who see a dentist on a regular basis and the 72 people who do not see the dentist on a regular basis, they are significantly different in the 2 scales. So this item can discriminate, can convergent, because people who see a doctor means they tend to have a better oral health. And people who do not see a dentist on a regular basis tend to have poor oral health. But see a dentist has little to do with the lonely scale, nutrition, or social support. So you can see that for the 3 scales here, we do not see any significance between the 2. So here show some evidence about discriminant validity. Okay, let's move to the second part of my speech is about the readability. As I said, we have to assess the validity first. If you do not have time or you do not have resources, you can just skip the assessment of readability. Readability is not very important. If you can show that your scale, your measurement are valid, and your measurement must be reliable. So here we can see in the textbook, there are 3 different reliability assessment indicators. The first one is test-retest reliability. The second one is a parallel form reliability. The third one is internal consistency. So if you can recall what I talked in the beginning about the reliability, in order to assess the reliability, we have to conduct the measurement at least twice. because the reliability is sometimes we call the reproducibility. How reliable? If you repeat the measurement, how the result, whether or not the result will consistently occur. So if the result can be reproduced, or the measurement results are very similar constantly, and we can say this measurement is reliable, is high reliability. So for the test retest reliability or the parallel form reliability, it's multiple tests or multiple measurements are required. But for the internal consistency, we don't need to do a multiple measurement. So I will go one by one to talk about the 3 types of reliability, and also show you some examples that some I have done before. Let's begin with test retest reliability. This is very popular method, and it can be used it is used quite often in many research. But even though this is popular, but the test retest reliability is not easy to perform, because the test reliability must be, to deal with some learning or forgetting problems in the test. Let me give you an example here. If I have a scale which is supposed to measure the quality of life, and then now we have, I saw that we have 200 participants in these online courses. If I have a scale that is supposed to measure the quality of life, and then I now give this quality of life scale to all of us, to all of you, 200 participants here. So everyone complete the quality of life scale now. Because I want to assess the test retest reliability. So when everyone finish the questionnaire, and I will collect all the finished questionnaire, then I will take a 10 minutes break. And then give the questionnaire again to all of us. And then you will have to do the test for the second time. Is there anyone who worry about this test retest? If I only take a 10 minutes break and then ask you to fill the questionnaire for the second time, I would expect many of you will give you the same answers, right? Because the break is very short, only 10 minutes. So everybody memorize what you have filled for the first time. So you will give the same answers for the second time. So the break, the time interval between the 2 tests are too short. So you will be able to carry over what you have learned, what you have filled in the first time, and you will write down the same answers for the second time. So probably I will show you a very high test retest reliability, but actually it's not a right thing, because we will not allow a very short period of time, because when the test retest with the interval is very short, the people will memorize what they write down in the first time and write down the same thing on the second time. But how about the interval can be as long as 1 year? If I ask you to fill a quality of life questionnaire now, and then I will make an appointment with you, and we'll meet together next year on the March the 1st. So 1 year from now, we will take the second time. How about that? How you feel about this type of test retest. If we have an interval like 1 year, I'm sure that you might be worried about this 1 year interval probably will be too long, because during a 1 year period, the quality of life may change. So now you have a level of quality of life. Maybe, you know, you make a lot of money and you have a very good job and you get married, you have a very good friends. So maybe 1 year from now, the March 1st, 2022, your quality of life increased quite a lot. So when I ask you to complete the second time measurement of your quality of life, maybe your quality of life has changed. So the first time and the second time will be different. It's not the problem of the questionnaire. It's the problem of the quality of life has been changed. So the problem with the test, retest, reliability will be the interval between the two tests should not be too short. And also it should not be too long. So what is the appropriate interval for the test, retest, reliability is not easy to determine. The parallel form reliability, which is commonly used in educational purpose. I don't know whether or not in Indonesia, high school or elementary school, whether a school teacher will use type of questionnaire. The test A and test B. In Taiwan, in high school, many high school teachers will use this type of test. You know, for example, I'm going to test the exam of the mathematics. So the school teacher probably will prepare for like 10 items. But sometimes the teachers, they are afraid that the two students sitting beside will cheat to look at the answers of their classmates sitting beside her or beside him. So the teachers will create two different home of tests, but the same items. They just use the same items in a form, but using the different orders. Like for the test A and test B, they are the same contents, but just a different order. The number 1 question in test A maybe is the number 5 items of the test B. So this is kind of for the makeup. But if you are using the test A and the test B for the same classes, the teachers must make sure that the test A and test B are reliable. They are consistent each other, but sometimes they are not consistent. For example, there is one item is very difficult to complete, and it could be listed on the first items on test A, but it could be the last item on test B. So when the students are taking the test A, they will face some troubles because every student will begin their test from item 1 to the last items. So this is the parallel form reliability, but we do not use quite often in our medical research by using the parallel form reliability. So the parallel form reliability and test retest reliability have to repeat the measurement in order to see the consistency. But as I said, it's not easy to determine the interval between the two tests or two measurements. So sometimes for easy performance, the research is using the internal consistency assessment for the reliability. And you can see a lot of different indicators for this kind of reliability. Sometimes you will see the split half reliability, Cronbach's alpha reliability, Coulter-Richardson 20 reliability. Those are all internal consistency. But actually, this is just a kind of statistics. The internal consistent reliability is important when we are measuring the construct. When internal consistent reliability tells whether or not we are measuring one thing or variety of things. And the measuring construct is challenged. As I said, patient satisfaction, quality of life, or the anxiety, depression is very challenged, and they cannot be measured adequately with a single items. So when we have multiple items in one scale, the internal consistency is something that you should consider to use to provide the information about the reliability. So let's give you some example about 3 types of reliability. The first one is test-retest reliability. This is a study conducted by myself and my colleagues from other departments. We are using the scale to measure the musculoskeletal disorders in the restaurant workers. Because people working in the hotel, restaurant workers, they have to do a lot of, to cook and to carry heavy, bags like rices or the vegetables. So they suffer from some musculoskeletal disorders, and we conduct a national survey. Actually, we use this questionnaire. We ask the workers to indicate which part of his body or her body suffer from pain, and what's the level of pain. So this is, we just adapt from Nordic muscular questionnaire, which is called NMQ, but we translate into Chinese and to survey about 905 hotel restaurant workers, and to show which part of the body they feel painful, and the level of pain. We also use a 5 scale, like a scale, to let the workers to indicate how painful that they feel during the work, and what's the coping strategy. Do you see a doctor or use a traditional Chinese medicine, or they just ignore the pain that they feel during the work? So this is a questionnaire, and before implement to the field, we just select a sample of our worker from our campus restaurant. We have students who are working in that restaurant, a very small number of students, and we ask the student to complete the questionnaire first, and then 3 weeks later, we ask the same students, they complete the questionnaire again, and we compare the difference or the agreement, the correlation between the two. So in this questionnaire, actually, this is my colleague, Dr. Chen. She calculates a Spearman correlation coefficient, saying that the test and the retest is quite close to each other. Use an indicator of 0.92. Well, here I want to say to you that many researchers are using the Spearman correlation coefficient, or using the the Pearson correlation coefficient to indicate the correlation between the two measurements. But here I want to say that this is not a right one. Actually, well, even though I'm the co-worker, but I did not talk to my colleagues, because she decided to use a Spearman. But if I were the main writers, I would not use the Spearman rule here, because I will show you that the Spearman correlation coefficient or Pearson correlation coefficient is not an appropriate indicator for the reliability, even though there are a lot of people using the reliability, because there is a test retest. The first test giving a scores, and the retest, the second test, also give a score. So many researchers, they just use the correlation to indicate the agreement between the two scores, but this is not the right one. I will give you some example here. So now we have the first test, like variable A. This is the first test. The variable B is the first test. Do you know the correlation coefficient for variable A and variable B? Because the variable A is 1, 2, 3, 4, 5, and variable B is 1, 2, 3, 4, 5. We can see that there is 100% agreement between variable A and variable B. So if you calculate the correlation coefficient for variable A and B, you will see the correlation coefficient equal to 1, because variable A and the variable B are 100% match. So if variable A is
Kalau yang konversi memang ada mata kuliah
if the variable A is the first time measurement, variable B is the second time measurement, and we will see that the retest readability is very high. But can you imagine the correlation coefficient between A and the C? What's the correlation between A and the C, A and the D, A and the E, and A and the F? And I can show you that all the correlations are equal to 1. Because all the scatter plot are on the same line. They're just with a different slope. So even though you can see that the A and the F, they're quite different. The variable F with a number is 4 times higher, 1.4, 1 times 4 equal to 4, 3 times 4 equal to 12. So if we have a test, we have the first test, we get the 1, 2, 3, 4, 5, and we have the second test, get the 4, 8, 12, 16, 20. Do you think that we have a good test readability? Of course, the answer is no, because the first test and the second test are quite different, but they still have a correlation coefficient equal to 1, because the correlation coefficient equal to 1 indicates that all the dots are on the same line. So the best way is to calculate the ICC, intra-class correlation coefficient. It's not the Pearson correlation coefficient, because only the ICC can, only the 100% exactly match. The numbers can, have an ICD equal to 1. This is just a very simple example about how to calculate, but I'm not going to talk about this, and you can see the slide. And I also, well, this is the same concept. I will ask you why there are two, because now we have a scale we call the sadness. It's not easy to measure the sadness. You feel sorry and you don't feel happy is a sadness. So now we have 10 patients here. We have 2 observers. We take the measurement of the sadness score. So my question is the same, just like I asked you in the very beginning of these courses. I will ask why the 20 numbers here, why there are variations in the sadness scores. Again, we have to make the analysis of variance. We will see the variance due to the patients, the variance due to observer. Of course, if the observers are the same, we will ignore this variation due to observers. So sometimes we call the intra-observer reliability. Sometimes we call the inter-observer reliability. It depends on whether or not the 2 observers are the same person or not. So we can use some statistics software like SPSS. This is calculated by SPSS. The SPSS can, if you fit these numbers into the software, will calculate the variance components, just like we said. So according to the formula of reliability, we can calculate the ICC is equal to 0.1. The calculation is complicated, but most of the software can calculate the ICC for us. It's not so difficult. You can just put the number here. So for this type of retest reliability for continuous variables, I would suggest you use the ICC instead of correlation coefficient. And this is another example that we calculate the ICC. I will skip this one. I will give you another retest reliability coefficient, but here we are talking about the categorical variables here. This was the one study done myself. It's a big national survey. I would like to see the exposure to the extremely low frequency magnetic field by children under 7 years old in Taiwan. So we took the measurement of indoor magnetic field by using the machines. So we use about 2 years. We complete a big national survey of more than 2,200 homes occupied by the children, the young children. So it takes a lot of time. So this is, we like to know how many children are living in a residential environment with magnetic field greater than 0.3 microtesla or even higher, greater than 0.4 microtesla. And because this is very time consuming and very expensive to do a measurement, because every time we go into a residence, we have to take a multiple measurement. We take the measurement at the living room, the bedroom, the kitchen, and other rooms. So it takes about more than 1 hour to complete a measurement of one single residence. So I'm thinking, can we just use the measurement at the children's bedroom? Because we know that the children's bedroom is a place that the children stay for most of the time during the day. Well, of course, the bedroom for most of us are, we spend like 7 hours, 8 hours per day in the bedroom. So can I use just the children's bedroom to represent the overall exposures? That's the best question that we're asking. So we just categorize the children's bedroom and the overall exposures into small than 0.3 microtesla or greater than 0.3 microtesla, and we construct a 2x2 table here. We want to see how consistent, how agreement, the level of agreement between children's bedroom, the measurement taken from the children's bedroom, and the measurement taken all over the household. And here, because now we are talking about the categorical variables, not continuous variables. For continuous variables, we can calculate the ICC, just I mentioned. And for the categorical variables, we should calculate the kappa. We should calculate the kappa to indicate the level of agreement between two categorical variables. I'm sure that you have seen this before in the textbook. And here I just want to show you how the kappa was calculated, but because of the time, I do not go through, but you can check my slide. It gives you the formula about the kappa, and you can see how can calculate the kappa. But again, the calculation is complicated. You have to calculate that things. Most of the software available, you can have the kappa. You just remember that the kappa is an indicator of readability that can be used to indicate the agreement between two categorical variables. Because for the readability assessment, we are talking about agreement because we have like a parallel form, or we have test retest. We have more than one test or one measurement. We have multiple measurement been done in order to assess the readability. So because we have a multiple tests, we want to see the agreement. And this agreement can be a continuous variable or the categorical variables. So for continuous variables, we should use the ICC to indicate the agreement between two continuous variables, not using the correlation coefficient. For the kappa, for the categorical variables, we should use the kappa statistic to indicate the agreement between two categorical variables. The last one will be the internal consistency. As I said, this internal consistency is an indicator of readability. And also, this is very suitable, appropriate for the construct concept for the measurement. This is one example that I use a questionnaire to assess the job stress or job dissatisfactions to a sample of petrochemical workers in Taiwan. So actually, I use 3 scales here. The job stress resources inventory, which is called JSSI, job stress reaction inventory, JSRI, and the job satisfaction scale, JSS. And you can see that for the JSS, we have 99 items. And for the JSI, we have 20 items. For JSS, we have 12 items. So these 2 scales covers, for each of the scale, they cover 99, 20, 12 items. So before we use these scales to a sample of petrochemical workers, we want to see that whether or not those petrochemical workers have high level of job stress or dissatisfaction level. So before using that, we have to conduct the assessment of reliability. So we calculate the Cronbach's alpha, which is very common in the scales. So we can see that the JSSI, JSI, and JSS, we have a very high, very good reliability coefficient. It's 0.98, 0.90. And also we calculate the other reliability coefficient that we call the Spearman-Brown split half. So in addition to Cronbach's alpha, we also calculate another indicator for the reliability coefficient. As I said, there are different types, even though the Cronbach's alpha is the one that most commonly used. So we just give another coefficient to the readers. So the Cronbach's alpha is, also the calculation is complicated. I just want to let you know that you can use some software that you're familiar with, like SPSS. I think is quite a friendly software that everyone can easy to get. It will give you the Cronbach's alpha here in the bottom of the out. And this is the formula for the calculation. And for those of you who are interested in the calculation, and you can see my slide and to see how the Cronbach's are being calculated. But again, I would say that you can use software to get easy answers from software. The Coulter-Richardson is also the same, but the Coulter-Richardson KR20 is an indicator that is more appropriate for the not the Likert scale, but also the knowledge scale. Sometimes we have a scale which only 2 answers, yes or no, and sometimes there is some. It's not only attitude. It's a knowledge scale, so I can judge whether or not you got the right response. So if you have that kind of scales, then the Coulter-Richardson will be the one that you should choose to indicate the internal consistency. So for the internal consistency, then we should use only we use only one measurement. We don't need to perform the multiple measurement because in internal consistency. Actually, you can see the word here, split half. It actually is just, artificially split the entire questionnaire into half. So it's really have 2 parts of scores for single questionnaire. This is also the calculation for Coulter-Richardson 20. And for those of you who are interested, you can take a reference of it. And the last one will be the exam for everyone. Because I'm sorry, I give a very quick talk, but the last one, I would like to give you a self-test and to see whether or not you can see what the author are talking about. This is one of my paper. I'm working with my colleagues from nursing department, Professor Tan. She did a study about the causes and the predictor of depression symptoms among family caregiver of terminal ear cancer patients. And we know that, for the memory caregivers who take care of the cancer patients is quite a lot of psychological burdens. And family caregivers will become depressed when they are taking care of their families who suffer from cancers. This depression, can become worse and worse when the cancer patients, to move to the end of their life. So here, Professor Tan, she used a questionnaire to measure the depressive symptoms. And I'm sure that some of you probably have used the same questionnaire to measure the depressive symptom, because this questionnaire is quite popular, which is called CESD. It's original from English version in the US, but now it's quite popular. There is a Chinese version being validated, proved to be valid and precise in the Chinese version of CESD. The CESD is a questionnaire that can be used to measure the depressive symptoms. It's not depression, it's depressive symptoms, because only the doctors can have a diagnosis of depression, but depressive symptom is a symptom. It's related to depression, but it's not depression. Depression is a diagnosis, only can be made by a psychiatrist, but depressive symptom can be measured by the CESD questionnaire. It's covered like 16 items. So this is the depressive symptom score for the family caregivers, back to, from 15.8 back to 17.4 when their families are moving to death. So this is the text written by Professor Tan. And my question is here, Professor Tan said that caregiver depressive symptoms were assessed by the CESD. The CESD have a score ranging from 0 to 60. The score greater than 16 indicate clinical depressive symptom. In other words, there is a cutoff point for the CESD, 16 points. Now, Professor Tan said the Chinese version of the CESD was translated by 2 psychiatrists who established scales internal consistency, test retest reliability, and the validity of case identification. Okay, now, there's the reference 24. Professor Tan just said that this Chinese version of CESD has been assessed for its validity and the reliability. Now, Professor Tan says some words here. She said this scales has an internal consistency. So you must know what she's talking about, right? The scale has internal consistency, means this scale has adequate reliability. Professor Tan said that this scale has test-retest reliability. I think that you must know what she's talking about, because this Chinese version CESD scales has been assessed by a test-retest reliability. In other words, there must be a previous study that used this multiple measurement of CESD. And the question is the last one. Not only reliability, but also validity. So Professor Tan, she talked about the validity of case identification. We just mentioned that there are 3 types of validity: content validity, criteria related validity, and the construct validity. But here, Professor Tan, she said, this Chinese version of CESD has the validity of case identification. My question is, do you think that Professor Tan, what type of validity that she's talking about? Validity of case identification. Can you figure out what she's talking about? What types of validity that she's talking about? Is content validity, or criteria related validity, or construct validity? Yeah, I will finish here. Anyone like to say something about my last question? Yeah, I would go back to. I will go back to. Sorry. Let me close the. No. Sorry. I will stop here. Yeah, go back to Dr. Sandy. Yeah, I just want to. Anyone want to answer my last question? What kind of validity that Professor Tan is talking about? The validity of case identification. In other words, Professor Tan said that she can use this Chinese version CSV to identify cases. What kind of cases? Depression. Depression. As I said, depression is a diagnosis. It can only be given by psychiatrists, by physicians, not the general people. Just people will say that, well, you have a symptom of depression. Of course, everybody can say that. But only doctor can say this person has a depression because that is a formal diagnosis. So Professor Tan said she is saying that this Chinese version CSV can be used to identify the real patients with depression. So it's kind of criteria-related validity because there is a gold standard. The gold standard will be the doctors. The doctor will give a depression diagnosis, and it's quite agree with this Chinese version CSSD. So there is a gold standard, which is doctor, and there is a measurement by CSD Chinese versions. So the last validity information talking by Professor Tan is a criteria-related validity. Okay, so that's all I want to present here.
Okay, thank you very much, Prof. Lee, for the interesting presentation and also for the very useful for us to know about the validity and reliability of health measurement. So now we come to the discussion. Or maybe I think there are many questions that you have to ask.
Yeah, okay. I will move from the last one, right?
Yeah.
If we find that, well, the assessment of validity and the reliability must be complete before to use this questionnaire in the field. So, I mean, just make sure that your scale, if you do not have a good validity and the reliability, and then you just go for the community survey, of course, there will be no any solution. I mean, you cannot just go for the field work without making sure that. So this problem, I just well, but sometimes, like myself, last year I created a questionnaire about the air pollution health literacy. I just want to know it is a government project to do a national survey because air pollution is so serious in Taiwan. Many people do not have enough health literacy to protect themselves. Especially during the winter time when air pollution is very serious. But the government gave me only like 8 months. And last year, it's really difficult for me to do a survey in the community because of the pandemic. So I want to use a telephone interview last year, but you know that the telephone interview would not allow a very long questionnaire. Because nobody will be patient to receive a phone call. So I just but health literacy is something that is not easy to measure. I create only like 24 items in that scale. And in the very beginning, I just take a quick assessment of reliability and validity. I use a construct validity, but it's not good. But I do not have time. I must go for. So, well, I'm sad. I mean, if that questionnaire is not, because I only covered 24 items, I don't think that questionnaire is valid enough. It's not able to measure what it is supposed to measure. So that's the point. But of no choice. But I would suggest if you have enough time, just make sure. If you, in your pilot study, you do a pilot study, and to find out the reliability or validity is not good enough, just modify your questionnaire. Make sure that they are okay. The second question, would you please send me?
Yeah, there is a question in the chat, Prof.
Yeah, I know.
Alenia Elisanti.
Yeah, would you please send me the I have reached it. Okay. Then what's this?
She asking about validity tests on the questionnaire. If not valid, so what we have to do?
No, if once the data are collected, there is no any solutions. I mean, just like we normally say that garbage in, garbage out, because you do not use a valid scales. So it's not. I mean, there is no solutions. So just make sure in the beginning, when you finish your data collection, there is no way to get any solutions.
Before, I mean, it's before we do data collection.
Yes,
we have to test, as you mentioned, to test in pilot.
Yeah. I normally myself,
yeah.
I will use like a small sample, like the 30, like the 30 people, and then we can have a brief feeding about the validity and the reliability. And if we find that in a pilot study with a very limited sample, we find that the validity or reliability is not good enough, then we have, you have to try to modify the questionnaire.
Yeah. So the second question is, I think, is related to if we have the value of the validity or reliability of the an instrument, how to increase the validity and reliability of an instrument?
Well, it's a trade-off. I mean, normally in the scale, just like last year, last year I used only 24 items trying to measure the outdoor air pollution health literacy. But this year, I have another project also given by Taiwan EPA. They want me to create another questionnaire, another scale to measure the indoor air health literacy, because indoor air pollution and outdoor air pollution are different. Many people are not familiar with the indoor air pollution, like the air pollution from the outdoor, from our furniture, like formaldehyde, or indoor smoking. Yeah, a lot of indoor, even though small cigarette smoking or ventilation is not good. We have carbon monoxide, we have carbon dioxide. So this year, I create indoor air pollution health literature scale questionnaire. I use 41 items, and it is very good. So if because health literacy cover 4 domains. The first one is access. Can you access the source of information? If you want to learn more about the indoor air pollution, can you access the information? The second domain will be understand. Do you understand the information that you get? The third one will be appraisal. Appraise. Can you distinguish between which information is right and which information is false? The false and the right is the number 3 domain. The last one will be apply. Can you apply those information that you collect to protect yourself from overexposure the air pollution? So the access, understand, appraisal, and apply is 4 domains. So in order to measure the health literacy, I don't think that you can use only like 10 items or 20 items. So last year, I used only 21 items because I have no choice. Because last year, we used a telephone interview. Telephone interview is not allowing too many items. So this year, I'm going to use a face-to-face interview, even though we still have a COVID-19 pandemic, but I decide to use a face-to-face interview. So I can create more items in my questionnaire. So I use 41 items. And so far, we are still doing a pilot study, but the preliminary result seems to me that it's pretty good. I mean, the construct validity is good. So if you want to have a valid measurement, you need to cover a wide range of the domains. But at the same time, the readability could be low. Why? Because you use, like for example, now I am doing the retest readability. One person has complete the 41 items. And several weeks later, he or she must complete another items. And because you have a lot of items, then variance will be increased. The variance increase, the random error will increase. Because the random error is a key component of readability. If the scale has a huge random error, the readability will be low. So sometimes, you know, of course, you can try to increase both at the same time. How to increase the readability? You must carefully design your items. And also, you have to standardize the interviewers, because when you are you train your interviewers, because you know the different people are to go for the interview, they will end up with different answers, just a different way of asking. So the standardization of the interviewers is essential in readability. So before our questionnaire to be implemented interview, we have we have several sessions of training of our interviewers. We have to make sure that all the interviewers are be standardized so that we can increase the readability of our scales.
Okay, thank you, Prof. Lee. And then we have next question.
Yeah, how many samples are minimal to test? Or 30 to 60. Yeah, myself sometimes it depends on how much time and how much money you have, because that is all about time and the money. Like myself, I normally will use like the 30 to 100 before as many as you can. But if you have like 100 people in your pilot, I would say that is quite enough to have a very good information about readability and validity. But you know, it costs a lot of money, because when you are doing a pilot using 100 people, you spend a lot of time and money, and those information may not be used in your real survey, because that's are using the older version of questionnaire. So at least 30. But if you can have more money and more time, probably you can increase your samples to 100, but that will be the maximum. No need for 100.
Okay.
Then,
thank you, Prof. And then we have next question.
Yeah,
from Nurul.
Homogeneity of the response.
Oh,
sure. So that's the reason why we're like myself now. I am doing my pilot study, because this year I'm going to collect like 600 interviewees all over the countries. The sample size will be like only 600. I want to use a face-to-face interview. So now I'm conducting my pilot the study. I have to this year I decided to use 100 samples in my pilot, and I used like I don't remember, like 20. I asked 20 experts. Most of them are from our nursing department, because our faculty in the nursing department, they use a lot of questionnaires. So I want them to complete my questionnaires. And for the rest of the samples, researchers must be aware that because when I use my questionnaire in the community will have a different kind of people. They will have different kind of educational background. They have different kind of occupation. So of course, the different backgrounds, they will affect the validity and the reliability of your questionnaire. So that's the reason why it is so important to make sure that all the items in your questionnaires can be fully understood. So that is also one purpose of your pilot study. Sometimes, we created items because we are professors, and perhaps I will ask my students, PhD students, they create items, but they have high educations. So they just write down the statement, the words, but those words may not be fully understood by the people who do not have higher educations. And if your target population cover a different educational backgrounds, of course, we must, in our pilot study, just make sure that all the items are clear enough and understandable to all people with all different educational backgrounds. Yeah, that's the answer is yes.
Okay, yeah. Thank you, Prof. Lee. So
Yeah,
now we still have a question, but we want to hear directly from the student, yeah, Prof. Lee.
Yeah, sure.
Please, Pauline, you can ask, you can speak directly to Prof. Lee.
Oh, yes. Hello, Prof. Lee. My name is Pauline. I'm an undergraduate student, third year in public health in Erlangga. I have I don't think it's a pretty significant question, but it just made me wonder a lot. I read, I was captivated by your last final test. I read the sentence that said, the CSV was translated by 2 psychiatrists. And that actually made me thought of construct validity. I mean, could one psychiatrist's interpretation differ from the other? If it's so, could this one be construct validity? I'm so sorry if I get the concept. Thank you so much, Professor Lee.
Oh, sorry. I cannot fully understand your question. You were saying that you have a question. You translate. You're making a translation.
No. Actually, she already wrote the question in the chat. Pauline, yeah. She is asking about the for your last slide.
Oh,
yeah,
okay.
CESD.
Oh, CSD.
Yeah. So she thought that that is a construct validity. Yeah.
You can do construct validity, and I'm sure that the CSD has been shown to have a construct validity. I'm sure that it also has a construct validity, but according to the authors, they say that they use this questionnaire to identify the cases. Here, the cases are the depression, the patients with depressions. So of course you can have the construct validity, but one psychiatry interpretation could be different from the others. But well, of course, but compare with the scales, the diagnosis by psychiatrists can be considered as gold standard. I mean, of course, different psychiatrists would have a different, even different psychiatrists, they are see the same patients, they will give them a different diagnosis. But anyway, they are considered gold standards as we compare to the questionnaire. Questionnaire is something that it can just identify to the people who have the symptoms, not the disease. Symptoms are not equal to disease. Only the doctors can, to give a diagnosis of disease. Yeah, but this questionnaire can be they can be assessed by for their construct validity. It's no problem, but not the last words in the papers.
Yeah. So maybe it's depend on the objective of the validity.
Yes,
that we have to measure. Yeah.
Well, so if you are going to, like myself, I last year and this year I am creating outdoor and indoor air pollution health literacy questionnaire. I had to do all types of validity assessment. Because when a questionnaire has a content validity, it doesn't necessarily mean this questionnaire has a criterion validity. So it's a different type of validity. But when you are using a questionnaire, you can choose only one of them, it's okay. But when you are creating a new scale, I suggest that you better to assess the different type of validity, because that will be easier for the researchers to use to have a comprehensive understanding of the validity issues.
I think it's the next question is
Yeah.
related to the previous one. Yeah. How to choose what type of validity? Yeah.
Well, if you have, as I said, if your questionnaire is measuring a construct, for example, the quality of life, depression symptoms, or the sadness, is something that is not easy to measure. Is a concept. You probably need to assess the construct validity. That will be better. And also, if you have a gold standard, then criterion validity would be better. But if you do not have time and you do not have resources, then expert validity will be enough. But personally, I do not like expert validity, because it depends on who are the experts. It really depends on who are the experts. And the CVI, which is Content Validity Index, is a kind of subjective. It's not objective. For the criteria-related validity and the construct validity, they are more objective. And the expert validity or content validity, the CVI, which is more subjective. So it depends on your questions.
Yeah, it depends on the question and also the objective of our
objective
study.
of your study and your data. And your data.
And data. Yeah. Okay. We still have 2 more questions. Is it okay, Prof. Lee?
Sure.
Okay. Effie, Ibu Effie or Effie, I think you can ask directly to Prof. Lee. Is it possible?
Yeah, thank you.
Oh,
Yeah.
Effie, okay.
Effie, please.
Yeah, thank you, Mrs. Santi. My name is Effie. I'm from Universitas Trisakti. Thank you for your nice lecture, Prof. I want to ask you about my research. Let's say I have a research about evaluate the surveillance system in Indonesia, and I have a questionnaire that I want to assess the validity and the reliability. Now, my question, the first is what are indicators that I used to determine the validity and the reliability of the questionnaire. The second, from your lecture, there is test retest reliability. Nah, what kind of consideration are needed to determine the time interval in conducting the retest reliability? Because from your explanation, is not easy to do the test retest the reliability. And the last question, how many trial are allowed, like minimal or maximal retest to determine the value of the retest. To determine value of test retest reliability. Thank you, Professor.
Yeah, okay. Avi, I will answer the second and the number 3 question first. Well, I have no answer for you. What's the interval is required for the test retest? As I said, it should not be too short and it should not be too long. But no textbook tell us how much time we need.
Yeah.
Because if you have too long for your interval, then the thing that you are going to measure may change. If you're too short, it doesn't make any sense. I mean, you already memorized what you have write down for the first time. So it's really not no easy answer. But according to what I see in the papers, sometimes several weeks to several months, but not longer than half year, not longer than 6 months. Because if you have an interval longer than 6 months, everything can change. So just make sure that things that you're going to change things that you're going to measure do not change. So that's what I learned. But it really depends on what kind of things. Maybe you can, for example, in the example that I give you, we take 3 weeks to take a test retest assessment about the workers in the restaurant. Can you imagine that if a workers, if a waiter or waitress working in the restaurant, he or she is okay because she or he has no any muscular pain. But how about 3 weeks later? 3 weeks later, maybe, because of her job or his job, he will, some kind of painful on his shoulder. Many things can happen within a 3 weeks period. So maybe you can think about this, what kind of the measurement that you're going to measure, and just make sure that the things that you're going to measure do not change quite a lot to determine your interval. And how many times or how many trials that are going to, at least twice, because for any indicator for reliability, kappa, ICC, we need to at least twice. Of course, you can have multiple measurement, and also we can also calculate the ICC and the kappa, no problems, but at least twice. And for your surveillance system in Taiwan, of course, we also have our surveillance system. I think the criteria validity will be the one that you should choose. For example, in Taiwan, I participated in the early years. When like more than 20 years, 30 years ago, when I was a student, my professor, he was in charge of the cancer registry. It's a surveillance system for the cancer registry. All the hospitals with a bed, 50 beds. 50 beds means moderate scale. For small hospital, they have only like 10 beds or 20 beds. It's a very small scale. At that time, the government required all the hospitals with 50 beds. They have to report to the cancer registry if they diagnose any cancer patients. But when we see this surveillance system, my professor, Professor Chen, he told us that in the beginning, they know that all the reporting systems are underreported. Many hospitals do not report confirmed cases of cancer to the registry. But they have no idea about how serious of the underestimation or underreporting of the cancer patients diagnosed in hospital. So they decided to do the validation study, how those reporting systems are underestimated. So they just go select some hospitals, go to the field, and to identify the cancer patients from the medical chart from each hospitals, and trying to to use those information. Because if you go to the hospital to see the medical chart and to see the pathological reports, of course you know who are the cancer patients, and trying to use this information. I'm not sure if you can see a statistics model we call the capture-recapture model. It's a statistics method. So you can use the capture-recapture statistics models to try to determine the magnitude of underreporting of the Taiwan cancer registry. So by doing this type of studies, we know Professor Chen, my supervisor, they know that how serious this reporting system can be in whole countries. And also the reliability, they just I think they use the test retest because they want the hospitals to report their cancer patients like several times, because the different hospitals have different reporting systems. They just ask the hospital, for example, they ask the hospital in Erlangen University to report your cancer patients for January 2021. And then several days later, they will ask the University of Erlangen Hospital to report it again for all the cancer patients diagnosed in January 2021. They report twice or 3 times, and they will see how stable of the information reported from the Erlangen University hospitals. So by using this information, they will see the cancer registration reporting systems in Taiwan. They will see how reliable this reporting system is and how valid this reporting system is. Yeah, that's what can I suggest that you can use this type of study.
Yeah.
Thank you,
So-
Professor. The
Yeah.
answer is very clear.
Yeah. So that is one of example that how important measurement in our daily life. In our activity, in our work. Yeah. We still have a question, Prof. Lee.
Yeah.
Yeah.
The interval.
Yeah.
We need.
I think it's almost.
Yeah, it's the same. The interval.
Yeah.
I have no a clear-cut rule for how long we have to wait for the second test. I have no idea. It really depends on the problem, because just like I mentioned, for the restaurant workers, 3 weeks may be too long, right? Because during the 3-week period, many things can happen.
Yeah.
Maybe this worker will get injury, right?
Yeah.
Because they carry a lot of things, and they have to do a lot of washes. So probably they will get some injury during their work, and you spend 3 weeks to do a second time measurement. Maybe their muscular disease has already changed. So it's really not a good idea to use 3 weeks. Maybe 1 week will be enough. So it's really, I have no answer. No textbook available that can give you this answer. How long should we take to do a second measurement? And what's the last one? The last. Oh no, that's the reported by.
Yeah,
it's yours.
It's
Yeah. It's
okay.
Yeah.
Is there any question again for students? Yeah, please, you can ask directly and speak directly to Prof. Lee. Is there any question? Pak Anas, ada yang mau ditanyakan? No. Student in 3rd year, did you have any question?
So how many time zones for Indonesia from west to east? Time zone.
How many?
Yeah, how many time zone?
Oh, time zone in Indonesia. We have
Yeah.
3 time zones.
Oh, only 3 time zones.
Yeah. What time now in Taiwan, Prof?
Oh, it's 1 hour ahead. And now it's 1:30 in the afternoon.
Oh, so only 1
hour difference.
1 hour. So
in Taiwan, 1 hour.
it's the same with the time zone in middle Indonesia.
Okay, I see.
We have 3.
Only 3.
East, middle, and west. Yeah. So now in Surabaya, we consider about west Indonesia.
Okay. So it's the same as Jakarta.
Yes, the same with Jakarta. Yeah, Jakarta, Bangkok, and Hong Kong, I think. Yeah. Oh, we still have one question. Yeah. May I ask follow-up question directly? Yes, please, Ibu Nurul or student Nurul, Dina, Rahmat.
Sure.
Yeah, please.
Ibu.
All right. Thank you very much, Ibu Santi.
Yeah.
Ibu San.
Yeah,
please.
Very sorry, Ibu. I'm actually not a student. I came from Universitas Indonesia.
Okay.
And Professor Lee. Yeah, thank you, Ibu Santi. Professor Lee, I would like to thank you very much indeed for a very enlightening presentation.
Thank you.
From the previous question, I asked you about the homogeneity about the respondents, right? And you said I have to make sure that my questionnaire is understandable for every single level of the educational background and so on and so forth.
Yeah.
Okay.
Your target population. Always consider when you are doing your real world survey, and who are your target population. So when you are doing a pilot study, even though you have only like 30 or 40 subjects, small samples, you always have to do your best trying to cover, to let your sample in a pilot study look as similar as the target population that you are going to do your survey. Make sure that everyone in your target population can understand what you're wording. Because some wording by people with higher education will be different from the wording by lower educations. Or even like in Taiwan, we have different, well, in Indonesia, you have a different culture and ethnic backgrounds. In Taiwan, we have, the people, our original people. We have, like now, we have 10% of mothers are coming from other countries. So a lot of people are coming from different cultural backgrounds. So we just need to make sure that not everyone have the same level of language. So make sure that your target population can truly understand what the questionnaire is going to deliver.
Yeah, right, exactly, Professor Lee. But then my next question would be, if I once done some kind of research on, it's a very specific respondent, Prof. We did the questionnaire, we did the survey to the elementary students, and it's all only for the 3rd grade. So we can make sure that all of the educational background are similar, and maybe their socioeconomic are also similar. So because they came from the similar neighborhood. So if the answer is quite similar one to another, does it mean that it will affect the reliability or the validity of the questionnaire? Because it might, they might answer the same thing. So we would also see similar score from each person. So what do you say about that, Prof? Thank you.
Yeah, sure. If the samples are quite similar in their family backgrounds or in their socioeconomic status, and also because I don't know what kind of scale, what kind of things that you're going to measure. If the things that you're going to measure are highly related to socioeconomic status, of course, it will be the story like just you described. But it doesn't, it still be okay when you're doing the reliability because it's the truth. I mean, all the responses are very similar because the things that you are going to measure are highly related to socioeconomic status. And also they are coming from the same grade, the same age, the same neighborhood. So yeah, but the problem is that if you are doing your survey on this kind of samples, I don't think that you can get the new information because from the statistic point of view, we were doing statistics. We like to see the variation. If the data do not show a sufficient variation, we would say that this survey would not tell us too more informations. So variation is important, but the story that you described is okay. You can still go for that. It's no problem. But just because I'm afraid that your study or your survey may not be able to provide more new information to your readers or to the scientific societies.
Yeah, I see. Thank you very much, Prof. Lee, because
you're welcome.
Yeah, the study was actually about the nutritional knowledge about
I see.
elementary students. I think it's quite relevant, right?
Yeah. It's highly related to socioeconomic status.
Yeah.
Okay,
Bu
so I still
Nurul,
can do. Yeah, Bu
are you
Santi.
a student or lecturer?
Oh, I'm actually a young lecturer.
In the Faculty of Public Health.
Yes, exactly.
University of Indonesia. So it's very surprisingly, Prof. Lee, we have many students from out of University of Erlangga. Okay.
I would like to thank you, Bu Santi and Prof.
You're
Lee.
welcome.
I'm really sorry I couldn't turn off the camera because it's quite messy here. But I hope.
Yes, it's okay.
Yeah, it's my pleasure.
Yeah.
Thank you.
Okay. Is there any question again, student? Yeah, I think validity and reliability of measurement is very important, especially if we if we are going to collect a data for research,
Sure.
it's very important,
Yep.
So we have to convince that our instrument is valid and also reliable, so the data is valid also, and the conclusion is valid also, Okay, I think we already passed from the time, Prof. Lee.
Yep.
Yeah, thank you very much for
My
your
pleasure. My pleasure.
time
Yeah.
to give a lecture to our student and also to our staff, not only from Universitas Airlangga, but we also have our the college from many university in Indonesia. And maybe for the next agenda, we can discussion first,
Sure.
Prof. Lee, about the topic,
Yeah.
And also, I think we have the same what we call the same method. We also offer our your lecture to our college and our student from not only from Faculty of Public Health, but also from other faculties and also from other universities.
Yeah, I will be pleased to do that as long as I can contribute.
Yeah. I think you just come from your holiday.
Yeah, today is a holiday in Taiwan.
Yeah, holiday.
Today is a
Taiwan.
national holiday. Yeah, today is a holiday. Yeah.
And also for Chinese holiday, I think. Yeah.
No, it's already finished. It's already finished. Yeah, already finished. 2 weeks. Yeah, only finished. Today is a memory day for the political victims.
Yeah. How many days?
Only 1 day, a Monday.
Only
today.
Monday.
So it's a long weekend from Saturday, Sunday to Monday.
Yeah, so it's a long weekend.
Yeah, long weekend.
Yeah. In Universitas Airlangga, we now in the second week for our new semester. Yeah, we start in the end of. We start last week.
We also started last week. Yeah, we also started last week.
Oh yeah.
Yeah. We begin the new semester last week.
Okay.
The same.
Yeah. Okay, Prof. Lee, thank you very much.
You're welcome. Hopefully, I can see you the end of this year in Surabaya for the APEC conference.
For APEC conference. It will be held in the end of October.
Yeah. Hopefully, it will come true.
I think you get the email from the committee.
Yes, I do.
For asking you as a speaker.
Yeah. I say that if I can go, I will go, but just not sure that if the pandemic, how far it will go, and also the vaccination. Have you already vaccinated?
Pardon?
Vaccination, COVID-19. Have you begin to the vaccination program? Vaccination program?
Yes, we already started in mid of January.
Oh, really?
So now we go to the elderly people.
Okay.
To get the vaccination.
Oh, we don't have vaccination. We don't have.
Still, you don't have.
No, we don't have vaccination. It's still no vaccination here in Taiwan. Nobody can get vaccinated. Nobody can get shot.
Yeah.
We don't have vaccination.
But your people in Taiwan is obey to the.
Social distance and wearing mask. Yeah.
The number of the daily cases is also low.
But vaccination is important. I mean, we definitely need to get shot.
Yeah, for the long term. For the impact of the others, not only health but economic and social. But I think in Taiwan the what we call the economic still going on. There is no lockdown.
It's okay. It's okay.
It's okay.
Economy is okay. Well, in our life, our daily life, we do not have much change. Only all the economic activities are still going.
And you still also open for other people from other countries, Yeah,
but you have to go for the 14-day quarantine.
For 13-day quarantine.
Quarantine.
So there is no difference. during this pandemic in
Not much.
your country? Yeah, not much.
Not much difference.
But you wear mask if you go to the outside.
Yeah, all the time. We have to go outside, wear the mask all the time. Yeah. Still, it's required. It's required. Yeah, for the restaurant and
the public area.
Yeah, public areas like stations, the transportation systems, and the indoor building, the department. Yeah, so it's required.
So your students still study from home or work from home?
No. We are in class, but we have a rule we can only have like a half of the seats been occupied. For example, if this classroom has 60 seats, then we will allow only 30 half.
30.
So yeah, only half. 30. If the classroom has 60 seats, and then this classroom can only be used for a small class. Like
so about the others?
If you have more students, you need to choose a bigger classroom.
Okay.
And if you have a very big class, like you have and no even bigger classroom is available, you need to split your class into 2 parts.
Okay.
And the other parts will be see the TV.
So you
give a lecture in one class, and the other student in the other classroom will see the TV.
Yeah. So you did a blended learning, yeah?
Yeah.
Oh, hybrid learning, yeah.
Yeah,
so
hybrid learning.
Can follow from the online, and then the others can come to the class and you give a lecture directly.
Sure.
Okay.
But we don't stay at home now.
Oh yeah, we still stay at home now. We still do it until.
Hopefully it can finish soon.
Yeah, maybe next week. Until next week. Yeah, but the mall is open, and others shop is open, but only for student. We still study from home. Yeah. Okay, thank you very much, Prof.
You're welcome. I'll see you soon.
Yes, and then we can discuss for the next agenda first, yeah. And also thank you very much for the student, and also Bapak Ibu has joined with this class. Thank you very much. Maybe we can announce, for the next agenda or the next lecture with Prof. Lee. Yeah. Okay, thank you very much.
See you everyone. Bye-bye.
Ya, bye. Terima kasih. Selamat siang para mahasiswa dan Bapak Ibu. Nanti kita akan umumkan kegiatannya dengan Prof. Lee berikutnya ya. Seperti yang kemarin kita akan buatkan posternya. Baik, terima kasih atas kehadirannya. Saya akhiri. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Nanti link YouTube-nya kita akan share lewat email. Bapak Ibu kan sudah isi email ya. Isi daftar hadir, nanti kita akan kirimkan linknya lewat email. Termasuk juga sertifikatnya ya. Baik, terima kasih. Ya, terima kasih. Selamat siang. Matur nuwun.
Matur nuwun Bu Santi.
Sama-sama Bu Nurul. Salam ya buat teman-teman di FKM UI Bu Nurul.
Oh, enggak Bu. Ada teman angkatan saya Konita di sana.
Oh ya, nanti saya sampaikan Bu Konita ya di tempat kami di S1 Gizi. Ya, nanti saya sampaikan. Ada salam dari Bu Nurul. Sami-sami, sehat-sehat semuanya.